To work? Circulation. Blood circulation. Their half-life is
120 days.
4 months.
Okay. After 120 days, what's happened for RBC?
It's going to spleen and they go to spleen and their spleen.
Exactly. We have a mesh like, actually, what was the name of?
Sieve.
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 Sieve, yeah, exactly. Sieve in actually English. In Arabic, what do you say? Sieve. Carbon, exactly. Sieve. Or carbon. Sieve was like that. Is that, yeah? I don't know exactly. I forget actually the spell of the C. It's like that. And those RBC, they are healthy and the shape is good. They actually has genesis. But some of the RBC which the shape is changed and they are old or senescence. They trap in upside the mesh. So, especially in the spleen. But also we have a system which is known as a reticuloendothelial system. Contain liver, bone marrow, and spleen together. But the spleen has the main role. In the spleen, these RBC are going to degrade. When RBC degradated, we have some part which is known hemoglobin. Okay?
Yeah.
Hemoglobin contains of what? Iron and protein. Globin. The globin part or protein part degrade to what? Amino acids. And amino acid can be used for protein synthesis again or other actually functions. So it's better to say we have a heme part, not F. Hemoglobin. Heme itself consists of two parts. Fe and porphyrin or pyrrole or anything you can say. So the iron has a different way. Yeah, we can send it to the bone marrow for producing new RBC. And we can send it to the liver and esterate it as a form of ferritin or hepcidin, and again use it for heme protein synthesis. So, but related to this part, when we degrade him to Fe and biliverdin at the first part is produced. Yana didn't bring a green marker for me. Biliverdin is a green. I wanted to write it in green, but I don't have green. No, it doesn't matter, just say. Biliverdin then convert to the bilirubin. And bilirubin also is yellow. Is not. Then bilirubin is not water soluble. You are going to eat lunch, breakfast, and dinner together. Bilirubin is not water soluble, and we need to add something to become somehow water soluble to transport it. Here, albumin take bilirubin and transport it to the liver. In the liver, we need to add something to bilirubin to increase water solubility.
Why?
water solubility. We need glucuronic acid. You remember glucuronic acid? What was glucuronic acid? When we oxidize glucose in carbon number 6, glucose convert to the glucuronic acid. In carbon number 1, glucose convert to the gluconic acid. You forget everything. Glucuronic acid is a glucose which has a carboxylic group in carbon number 6. So we added 2 molecules of glucuronic acid to bilirubin and we produce conjugated bilirubin. This conjugated bilirubin is somehow water soluble and then sent to the intestine. In the intestine, the glucuronic acid removed from bilirubin by bacteria in the intestine and convert it to the urobilinogen. Urobilinogen in the intestine have two phases. One of them convert to the acetylcholine The color of feces is what?
Yellow.
Feces.
Brown.
Brown. Brown to yellow. Brown. Why the color of feces is brown? Because of acetylcholine. Because of acetylcholine. Then urobilinogen go back to the liver and then to the actually circulation. Then go to the kidney. Hassan, I come here and actually draw a kidney. I can't draw it. Somehow imagine it's a kidney. It's not a real kidney.
This kidney with some
I
disease.
can't tell you. I don't know what it is. It's not real. Somehow, imagine it's a kidney. In the kidney, urobilinogen convert to the urobilin. And urobilin excrete in the urine. And urine color is yellow. Yellow. Why is yellow? So the both color of feces and urine, it's because of the product of heme. Here you can see all the actually mechanism that I talked about here. First of all, in the bone marrow, we produce RBC. We need iron, we need globin, vitamin B, that was vitamin B12 and erythropoietin together. They lead to increasing RBC production. RBC go to the blood circulation for 120 days. After that, in the spleen, by macrophages in the spleen, they trap this RBC, senescence RBC. RBC can
There's
be
no
degraded
pointing.
to heme and globin.
Doctor, there's no pointer.
So when I focus, we cannot use a pointer. If I am going to use a pointer, I have to actually zoom out. Let's do. Okay. Yeah. At the same time, we can use both. Let's do right hand. Pen up also. Here, in bone marrow is produced, go to the circulation for 120 days. Then the senescence, they trap in the macrophage of spleen. This part RBC actually break down and hemoglobin is released. Hemoglobin convert to the hem and globin. Globin convert to the amino acid, and amino acid again are used for protein synthesis. Hem convert to the biliverdin and iron. Iron can be actually transferred to the liver and storage as a form of ferritin, or by transferring sent to the bone marrow again. And here are used for RBC synthesis again. But related to biliverdin, we convert to the bilirubin, bilirubin sent to the liver. In the liver, we conjugate it, we send it to the intestine, and in intestine, we actually excrete it in a circulating form or send it back to the kidney and excrete in the urine. It's the whole pathway of the bilirubin metabolism. Yes?
Why is the iron, it's transferred to the liver? There it says ferritin. And then it says quickly transferring transfers the iron. But what is the job of ferritin?
You didn't hear about the function of ferritin? No one? Ferritin is a storage form of iron. When we are going to storage iron in the liver, we storage as a form of ferritin. Just. So, we can divide heme metabolism to 3 parts. Before liver, inside liver, after liver. So we call it prehepatic, hepatic, and post-hepatic part. So, and if we have a dysfunction in each part, lead to the jaundice. So we have 3 kinds of jaundice: prehepatic jaundice, hepatic jaundice, and post-hepatic jaundice. All those actually reasons, they lead to the increasing hemoglobin degradation, RBC degradation. They are known as a prehepatic jaundice. Like bleeding, like actually different kind of anemia or G6PD deficiency or so on. Those actually reasons, they are related to conjugation in the liver. They are known as the hepatic. For example, we have a Krieger-Najjar syndrome, Gilbert syndrome, Dubin-Johnson syndrome, Ray syndrome. They are the disease related to hepatic. And also related to post-hepatic, we have a Rotor syndrome. We have actually bile duct obstruction. So I will talk one by one. Here we have a hemoglobin convert to the globin, amino acid group. Heme convert to the bilirubin and then excrete. So near to 75% of the bilirubin derived from RBC. In a normal adult, daily we actually produce 250 to 300 milligram of bilirubin. The normal plasma concentration of bilirubin is less than 1 milligram. Can you remember the case I introduced?
Yes.
9 milligram.
It was 9 milligram.
Yeah, serum.
So, because bilirubin is so hydrophobic, it can't transfer easily. So, transportation is occurred by albumin to the
So this is plasma bilirubin.
what?
This is plasma bilirubin.
Plasma,
Yes.
bilirubin.
Yes. Because in the case study it says plasma bilirubin 0.9 and then conjugated bilirubin 0.7.
Let's we understand. I'm actually I'm going to the next slide, then we can understand what is the differences. After heme catabolism, we have an enzyme here known as a heme oxygenase. Heme oxygenase meet in ADPH and actually convert him to the biliverdin, which biliverdin is green. And here iron is released and carbon monoxide also is produced. The only enzyme in our body which produce carbon monoxide is heme oxygenase. And CO is exhaled. Exhale. Breathing out. Biliverdin reductase convert biliverdin to the bilirubin, and bilirubin color is yellow. If you actually hurt some part of your body, you can see the color of your skin change during the time. First of all, it changed to this color, then to the greenish, and then yellowish, and disappear. You know what is the reason of changing this color? Because of bilirubin, biliverdin, and so on. Okay? If you hurt your body, you can see these changing in the color.
Doctor,
And the color is because of biliverdin, bilirubin.
why the diabetic person have this pigment in his skin more than normal person? It's related to? Because
No.
I've seen this case.
No, diabetic, they don't have this kind of actually pigment.
When he have it, this pigment is still for more than normal person.
I think that's because they bleed more easily, diabetic people, so they bruise easily, not because of.
I don't know exactly about diabetes. I didn't see that, and I don't know exactly.
I have a question. Sometimes when we bruise, ourselves, when we get black color at the end, what is that blackness?
Black is not black really, is dark blue. Dark blue is an unoxygenated hemoglobin. So here you can see inside the macrophage, by heme oxygenase convert to the biliverdin. Biliverdin is a linear form of porphyrin. When we open porphyrin, biliverdin is produced. Then convert to the bilirubin by reductase. Finally, by albumin, transport to the liver. In the liver, we added 2 molecules of glucuronic acid, and then we send it as a form of bile to the intestine. First to gallbladder, then to the intestine. Please pay attention to this picture from the beginning to the end. I will explain, and you can understand the whole pattern. First of all, the senescence red cells, they trap by spleen, by macrophage in the spleen. Then, heme convert to the biliverdin and bilirubin. So bilirubin is transported to the liver. This bilirubin, known as a unconjugated or indirect or unconjugated, is the first bilirubin. In the liver, we will add a conjugated or glucuronic acid, and we produce conjugated bilirubin, CB. Then CB is sent to gallbladder and to the intestine, because bilirubin is a part of bile. In the intestine, bacteria in the intestine remove glucuronic acid and convert it to the urobilinogen. Okay? Convert to the urobilinogen, U. This urobilinogen, some part, actually most part of it, near to 70%, convert to the stercobilin and excreted in the feces. So near to 30% reabsorb to the liver. We call it, actually there is a cycle, enterohepatic cycle, intestine and actually liver together, between urobilinogen. Some part of it absorbed by liver, and again near to 10% go back to the intestine. But near to 15% sent to the blood circulation, to the kidney, and in kidney convert to the urobilin. Urobilin. And urobilin excrete in the urine and is responsible for the yellowish color of the urine. Here are actually the conjugated bilirubin glucuronic acid receive 2 molecules of glucuronic acid. We have some disease, I will talk about them in the next slide again. You can see red blood cell, hemoglobin, heme, biliverdin, rubin by albumin sent to the liver. In the liver, 2 molecules of glucose by glucuronic transferase are added. They are glucuronic, and then we send them to the gallbladder. In the gallbladder, as a form of bile, we send them to the intestine. In the intestine, convert to the urobilinogen, some part to the stercobilin, excreted, some part to the kidney, the urobilin. So, the first, what's happened? Give me the answer.
That is
This is D. It's A.
either A or B.
A or B. One of them.
Either of these two.
A or B?
B. B.
C.
A.
What is the green pigment? Biliverdin. What is the pigment?
What's happened for the keyboard? Which one?
C.
Okay.
Shouldn't it be like C and B as well? Oh no, but this time
B.
It's B. Where is it?
A.
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 What is the end product? B.
Okay. So, what do you think about the number of hemoglobin in one RBC?
Four.
How many hemoglobin we have in one RBC?
4.
4
It has 4 subunits.
has a 4 subunits, but how many hemoglobin
One,
molecules we have?
because it
One.
takes each RBC takes 1 oxygen.
Each RBC take 1 oxygen.
No, it's more than 1 oxygen.
4 or 3?
What do you think? Can you give me a number?
So can you give us the approximate sizes of each?
Medium. A medium. 100 million.
No.
100 million.
100. 2.
Each RBC. Each RBC has near to 270 million hemoglobin molecules. Okay. And lifespan is 120. And daily, 100 to 200 million RBC are broken down. Okay, can you imagine? 100 to 200 million, which each of them has a 270 million hemoglobin. And actually, daily 6 gram hemoglobin is broken down. And the bilirubin concentration in all the day is 300 milligram, which concentration is near to 1 milligram per deciliter. So all of these molecules are broken down, and the concentration of milligram in bilirubin is 1 milligram per deciliter. So we can report conjugated and total. And unconjugated is calculated. So we don't need unconjugated. If we have a total and conjugated, they are enough. Conjugated concentration is 0 to the 5 or 0 to the 0.3 milligram per deciliter. And total is about 1 milligram per deciliter. Why you come to the class? Just for the actually having a fun time? They don't care at all.
They were eating at the cafeteria with me.
No, I don't talk about what they did. I'm saying why they come to the class. Why they are coming to the class. They don't need to come. Unconjugated 0 to 0.3 and about 1. But in neonates, bilirubin concentration is high, maybe to 10 milligram per deciliter. Maybe to 10 milligram per deciliter in neonates. So we have a disease which is known as a jaundice. Jaundice is yellow color of the skin and white of the eye also, they are yellow. It may be characterized increase in unconjugated or indirect, or conjugated or direct, or both. It's dependent on the source of increasing in bilirubin. Accumulation of bilirubin, usually unconjugated is accumulated in the brain, lead to the disease known as a kernicterus, which result in this. So you can understand why it's so important in neonates we control the bilirubin concentration and do not allow bilirubin be high in neonates, because bilirubin transfer to the brain and lead to the kernicterus, which is so severe disease, and finally lead to the death. The jaundice can be due to the hemolytic crisis, can be due to the dysfunction of glucuronide transferase or hepatic damage, or maybe bile duct approach. Especially you guys are going to work in Iraq. Because of the prevalence of hepatitis in Iraq, they have a lot of problem in their liver. And all of hepatitis, guys, they have a bilirubin concentration is high. And if you look at some people column, you can find out they have a problem in their liver, because it's completely clear. And unfortunately, the hepatitis prevalence is high in Iraq. So you will have a lot of patients with this kind of disease. What is hemolytic crisis? Hemolytic crisis, it means when some reason lead to the increasing of RBC degradation. Severe hemolysis is occur. It's an unconjugated and total bilirubin is increased. Okay? Why severe hemolysis is occurred? Maybe due to the G6PD deficiency. You learned G6PD deficiency. What was that? Glucose-6-phosphate dehydrogenase. It's important in which pathway? Pentose phosphate pathway. For production of what? NAD. NAD, which is important for maintenance of glutathione. Glutathione is important for maintenance of RBC membrane. So when we don't have this enzyme, we don't have NADPH, we don't have glutathione, the RBC membrane is degraded. So hemolysis is active. especially those patients they have a FABIs. And those patients, if they use no alcohol, bakura, soybean, like that.
Beans.
Beans. Beans.
Some type of people who have this allergy.
Exactly. And also sickle cell crisis. Sickle cell crisis. Those patients they have sickle cell anemia. If they go to the mountain or actually to the sea or some places which the pressure of oxygen is low, it lead to the sickle cell crisis and actually anemia and hemolysis crisis. And RH disease of newborn. What is that? The RH of the baby with mother is different and lead to the RH disease. So hemolytic crisis can be confirmed by low hemoglobin and elevated of reticulocyte count.
Doctor, the RH disease in newborn, you mean when the R group, when the blood group of the child is different from the mother, and then after that, the mother will produce antibodies against the red blood cells of her child.
Somehow, not completely, but you will study in hematology. I don't want to talk about RH disease because it's not related to this course, but just know RH disease lead to the hemolytic crisis. So, in hemolytic jaundice or neonatal jaundice, both of them unconjugated bilirubin is increased. If you look at that, eyes, you can see. Where is eyes? Here. Completely is yellow. And actually, this patient has jaundice, but after treatment, the color skin actually completely returned to the norm. He's a patient with jaundice and also hepatitis. So, did you hear related to jaundice in newborn? How many percentage of the newborn they have a jaundice?
I think it's a high amount. I'm not sure exactly how, but it's a large.
90%.
60-70%. What about the, we have two kind of neonate, newborn. Those actually are mature and they are immature, or preterm. What about the preterm?
They get preterm.
Preterms are more susceptible to have jaundice
Why?
because their liver isn't fully developed yet.
So if you look at here, we have a urobilinogen glucuronine transfers. Okay? Bilirubin glucuronine transferase activity. In the full term, glucuronine transferase activity is high, and they can add glucuronine to bilirubin and excrete it easily. But in the premature or preterm baby, because the glucuronine transferase, because of the liver is not developed very well, is low, and then the concentration of the serum bilirubin is higher than the full term. So you can look at the baby with the jaundice, and what we are going to do for this child? Phototherapy. Phototherapy. Actually, there is some machine tools which they produce a blue light.
We call
Blue
it
light.
footage.
What?
Footage.
Blue light. Okay, this blue light, what is going to blue light? Actually, we have a bilirubin structure. It consists of
It's going to destroy.
actually hydrolyze this bond and help to excrete it easily. So if baby bilirubin be high, we need phototherapy. Related to full term, near to 60 to 70% of the baby, they have a jaundice. But related to preterm, near to 90% of the preterm, they have a jaundice, and we have to treat them.
Before there was blue lights, what did they
Just
do?
they actually in front of the light, outside. Because actually sun also has a blue light, and also it can be helpful. But the blue part is more efficient than the whole light. But if you don't have blue, you can actually put it in the outside, but not during all the day. Just for example, 30 minutes, half an hour, then
So,
for 2 or 3
for
hours.
example, if a child is born with jaundice, instead of giving them the blue light, it is okay, for example, to just sit outside with them 1 or 2 hours a day.
Yes.
Also works.
Somehow it's work. Somehow it's work. But you should be careful about the temperature, about the other thing, about the burning, and actually it's somehow difficult. What does the phototherapy do to bilirubin in newborn?
Converts it to
Hydrolyzes it. I don't know.
Which one? No.
A.
No.
Z.
C. So, related to type of jaundice, we have a pre-hepatic, hepatic, post-hepatic. Memorize. Hemolytic anemia are actually categorized in this part. Hepatitis, cirrhosis, Krieger-Najjar syndrome, Dugin-Johnson syndrome, Rotor syndrome, all of them are hepatic. Gallstone, malignancy, and inflammation are known as a post-hepatic. Related to UDP glucuronide transferase, we have a this syndrome, Krieger-Najjar, type 1 and 2, and Gilbert syndrome are due to the deficiency of this enzyme. Any kind of hepatic damage, viral hepatitis, cirrhosis, fibrosis, all of them, they lead to the increasing in bilirubin. And also we can see increasing in aminotransferase, and also those people, they actually are alcohol abuse, they have a problem with increasing in bilirubin. So orally, you can look at this table in a normal concentration, in normal people, serum bilirubin, indirect and direct, urine urobilinogen per 24 hours, and urine bilirubin is absent, and fecal urobilinogen is visible. But in hemolytic anemia, indirect is increased, urine urobilinogen also is increased, bilirubin in the urine is absent, and fecal urobilinogen is increased. In the hepatitis, both direct and indirect are increasing. Urine urobilinogen decreased, urine bilirubin actually present somehow, and fecal is decreased. In obstructive jaundice, direct is increased. Urine urobilinogen is absent, urine bilirubin is present, and fecal urobilinogen is trace or absent. So, I'm talking about the heme and bilirubin just in a brief review. I wanted to talk about urea and creatinine. You learned what is urea. Urea structure was here, you can see. This is the structure of urea. And protein convert to the amino acid, to ammonia, and finally to the urea. Urea has the highest concentration in the blood urine, and near to 40% of the urea is actually excreted in the urine. A plasma level of urea is dependent on diet, liver function, kidney function, and state of the hydration. The main reason of causes of decrease in urea. Actually, if we have a decrease in protein intake. If we have a liver disease, normal pregnancy, severe vomiting or diarrhea, and increased protein synthesis, high fluid intake, they lead to the decreased urea. And the main reason for increasing urea is actually can be divided to three reasons: pre-renal, renal, and post-renal. For pre-renal, we have some actually situations like dehydration, stress, hemorrhage. Renal, all kind of disease related to kidney, like pyelonephritis, diabetes, nephrotoxis, renal failure, and post-renal like stone, gallbladder, and actually bladder obstruction. Final actually part of today is related to creatine and creatine. What is the difference between creatine and creatinine? Is a creatine and creatine. Can you give me the differences?
Is used by muscles when they turn to creatine.
Okay.
Or is reverse? When creatine can be used by muscles, use one of them and turn to used to store. While creatine is a resource.
So creatine is the actual,
Keratin make keratin.
Creatinine is the waste product from it.
Exactly. Creatine is synthesized in the kidney and the liver from arginine and glycine. Together they produce guanidoacetoacetate, then sent to the liver. In the liver, by receiving a methyl, convert to the creatine. And in the muscle, here is the actually pathway of synthesis. In the muscle, creatine convert to the creatinine and actually is a waste product. Both phosphocreatine and creatine can convert to the creatinine. Is a waste product present in all body fluid, filtered through the glomeruli and excreted in the urine. The adult concentration in the serum is near to 1, female is near to 0.8, child 0.6. And value greater than the 1.5 indicate renal failure. So it's so important evaluation of creatinine. But the concentration of creatinine, in addition to liver function, is related to muscle mass, creatine turnover, and mostly related to the renal function. Is the most important factor for evaluation of renal function. And we can calculate GFR based on the creatinine concentration. So, and uric acid for the next part. So, do you have any question? So we can have a 5-minute